Hello, I'm Dr. Malcolm Robinson, Associate Chair for Clinical Operations in the Department of Surgery at Brigham Women's Hospital and Director of the Nutrition Support Service. Today we're going to be talking about fundamentals of clinical nutrition, essentials for the critical care specialist. I have no financial disclosures pertaining to this presentation. The first question that often comes up is, why should one care about this particular topic? And this is attached to the notion of how does malnutrition affect outcome in the ICU. Surprisingly, there's been little data that has specifically looked at this question, although it would seem intuitively obvious that malnutrition may affect outcome. To address this question, our group studied nutritional status and mortality in the critically ill. It was a single center, registry-based observational cohort study who looked at 9 medical and surgical ICUs in one hospital, Brigham Women's Hospital, and we studied approximately 6,500 patients who were of adult age who received a formal standardized evaluation by a registered dietitian between the years of 2004 and 2011. One of the problems with nutritional studies is there's no good way of assessing nutritional status by laboratory means, and one thing that we were able to do in a prospective way was have the dietitian identify those who were at risk or who had frank malnourishment to increase the validity of our study. Our primary endpoint was 30-day all-cause mortality following critical care initiation. Our secondary endpoint was the pre-specified secondary endpoint of 90-day all-cause mortality. We used vital status for the study cohort, which was obtained from the U.S. Social Security Administration Death Master File, and we had a 100% follow-up at up to 1 year. The bottom line in the take-home message, maybe not surprisingly, is that those who are malnourished versus those who do not have malnourishment are at markedly increased risk of mortality. At the 30-day mark, we found that those who were assessed with protein energy malnutrition had a 2-fold increased risk of mortality. And at 90 days, those who had protein energy malnutrition compared to those who did not had almost a 3-fold increased risk of mortality. So as you can see, nutritional status is an important factor in the outcome of those who are critically ill. That as a background, what we're going to talk about today is a nutrition assessment, determining when and how to feed, tube feeding, and the basics of TPN. So let's start with nutrition assessment. The basics of nutrition assessment begin with obtaining a medical history. You want to get laboratory data and a history of recent weight change. You want to determine the nutritional status. And one of the ways of doing that is determining whether one is well-nourished versus mildly, moderately, or severely malnourished. You then want to move on to calculate calorie and protein requirements and then make recommendations regarding nutritional intervention, if any is indicated. In terms of the classification, one of the ways of doing a simple classification of malnutrition is looking at the percentage of usual body weight. For those who are in the 85 to 95% of usual body weight, one can characterize them as being mildly malnourished. In the 75 to 84% range, moderately malnourished, and anybody who's less than 75% of their usual body weight is severely malnourished. Now, it's important to recognize that when we talk about usual body weight, that we're not talking about ideal body weight, we're not talking about body mass index, and that, of course, has implications regarding whether somebody who is obese can be malnourished or whether somebody who is extremely underweight is automatically malnourished. And so we actually look at the usual body weight as a very important predictor or assessment of one's malnutrition status. You can also use predictive equations. Due to time limitations, I can't go into the specifics of these equations, but there's a Nutrix score. Alternative things that people can do is use laboratory values, such as prealbumin, to assess one's nutritional status. Newer assessment parameters that are beginning to come into play involve looking specifically at energy intake and weight loss over time. We want to assess loss of muscle mass and subcutaneous fat stores on physical examination. It's interesting to note that if you look at localized or generalized fluid accumulation, that there's going to be some connection between one's nutritional status, particularly if there's anasarca. And then we want to look at diminished functional status, and this can be measured by hand grip strength. Using these new parameters, a new way of making the malnutrition diagnosis is based on the etiology. And so the first question that one might ask is inflammation present? No, yes. In the ICU, almost 100% of the patients are going to have some inflammation present. And if that is mild to a moderate degree, then they may be characterized as having chronic disease-related malnutrition. And this will be seen in people who have organ failure, pancreatic cancer, for example, rheumatoid arthritis, or sarcopenic obesity. If there's a marked inflammatory response, one may characterize this as acute disease or injury-related malnutrition, and this will be seen in those who have a major infection or sepsis, burns, traumatic injuries, or closed head injuries. And so we'll be moving away from the old characterizations of nutritional status and moving towards these new characterizations as time goes on. As I alluded to previously, one of the questions that often comes up is, can obese patients be malnourished? And then the other question that comes up is, are obese people protected from bad outcomes in the ICU if they are malnourished? People may have heard of the obesity paradox, where one who is obese may actually be protected because they are obese. And so one of the things that we wanted to do with our database is, in another study, look at the relationship among obesity, nutritional status, and mortality in critically ill patient populations. Again, this was a single-centered registry-based observational cohort study that was conducted in 9 of our medical and surgical ICUs, involving 6,500 adult patients who did receive that formal standardized evaluation by a dietitian. This was particularly important in obese patients for whom it might be very difficult to assess whether they are quote-unquote malnourished. And so having a registered dietitian who is an expert in making this analysis was key to doing these analyses. So when we looked at the group of 6,500 patients and stratified them by BMI category, as you recall, a BMI less than 18.5 is considered abnormal or underweight. Those with a BMI of 18.5 to 25 are considered in the normal range. 25 to 30 is considered overweight, and anything above 30 is considered obese. And those who had a normal BMI, not surprisingly, about a third of them were well nourished, about 55% had non-specific malnutrition, and then about 15% of them had specific malnutrition. For those who were at the extremes of obesity, there was an increased likelihood of them being well nourished, which makes intuitive sense, and a markedly decreased risk of them having specific malnutrition. But that being said, we want to go ahead and see whether there was an association between a nutritional status and obesity. And what we did find is that if you look at the adjusted odds ratio for 30-day mortality in obese critically ill patients with and without malnourishment, that you almost had a 60% increased risk of dying if you were malnourished compared to those who were well nourished. So in answer to the question, can obese patients be malnourished? The answer to that is yes. And are obese people protected from bad outcomes in the ICU if they are malnourished? And the answer to that is no. And because of this, the guidelines from the American Society for Parenteral and Enteral Nutrition regarding the nutritional support of hospitalized adult patients with obesity clearly states that all hospital patients, regardless of BMI, should be screened for nutrition risk within 40 hours of admission, with nutrition assessment for patients who are considered at risk. Bottom line, obesity is not protective, and one needs to treat obese patients in the same fashion that they would treat non-obese patients with respect to assessment and treatment of nutrition. Let's move on to talk about estimating energy requirements. There are many, many ways to estimate caloric needs. Predictive formulas exist for different populations, in the ICU, in obese people, in elderly people, and amputees, et cetera. Two of the most common ways to estimate caloric needs are the Harris-Benedict equation and basing caloric needs on weight alone as kilocalories per kilogram. So one of the most commonly used formulas is the Harris-Benedict equation. And the Harris-Benedict equation is divided between male and female patients, and it's based on weight, height, and age, and there are different formulas. What that allows one to do is to figure out the daily caloric requirement based on metabolic rate. But you have to know that the basal metabolic rate should be multiplied by an activity factor, which ranges from 1.0 to 1.3, depending on whether they are intubated and sedated in the bed or whether they're up and walking around, and the disease stress factor, whether they've had say, an appendectomy or a relatively straightforward operation, or whether they, for example, have a 90% total body surface area burn. And so again, if you're using these predictive formulas to look at basal metabolic rate, you need to multiply the number that you get by an activity factor as well as a disease stress factor in order to come up with the total daily caloric requirement. So, alternative way of measuring daily caloric needs is may be estimated based on body weight alone. For seriously ill, hospital caloric goal may be estimated as roughly 25 to 30 calories per kilogram. It used to be that we were prescribing higher caloric goals for patients, more in the range of 30 to 35 calories per kilogram. But there's suggestion now that in the immediate aftermath of somebody who's acutely ill, that all the caloric delivery of nutrients, particularly carbohydrates and fat, may not be utilized appropriately, and that you do not need as much calories in that immediate period as once was thought. However, you do need significant amounts of protein, and so we're now moving to a paradigm of hypocaloric feeding in a setting of providing adequate protein. In short, for seriously ill hospitalized patients, the caloric goal can be roughly estimated at 25 to 30 calories per kilogram. Now, you should know that calorie needs based on predictive equations and weight alone can be very inaccurate. Such estimates may be off by 20% or more in many populations, as the obese patient, burns, fluid overloaded, amputees, head trauma patients, and hence the gold standard is something called indirect calorimetry, or obtaining a metabolic heart study to determine REE, or resting energy expenditure. Indirect calorimetry is the assessment of resting energy expenditure and respiratory quotient by measurement of oxygen consumption and carbon dioxide production. The complete formula for determining is based on the Ware equation, which in addition to looking at O2 consumption and CO2 production, looks at urea nitrogen. Measuring urea nitrogen in the urine is very difficult and not clinically pragmatic. And because of this, people use the abbreviated formula, which can be done using the metabolic cart to look at oxygen consumption and CO2 production. Once you obtain the resting energy expenditure, the daily caloric requirement is multiplied by an activity factor. Note that because we're making a measurement in a critically ill patient, that you do not need a disease stress factor, you just need the activity factor. And this is in contrast to those who have predictive formulas where you multiply the basal metabolic rate by a disease factor as well as an activity factor. There are situations in which a metabolic cart study may be inaccurate, and one needs to be aware of this in the ICU. If, for example, all exhale gas is not collected, you will not be able to accurately determine CO2 production. This may occur, for example, if there's leaks around the tracheostomy tube cuff or their chest tubes. If you have chest tubes and you have an air leak in the chest tubes, then you may be losing oxygen and inaccurately measure oxygen consumption. And you may inaccurately leak CO2 and inaccurately look at CO2 production. If you're doing measurements during dialysis, the CO2 may be dialyzed off and therefore be accurate. Nitric oxide therapy, and if there's not steady state achieved. You should note that metabolic heart studies are generally done over approximately a half an hour period. If the patient is not in a quiet setting and has spikes in their temperature or their activity, and then you extrapolate the measurement from a half an hour to 24 hours, is going to be wildly inaccurate. And so you want to make sure the steady state achieved and the patient's in basal conditions and not being disturbed during the study period. In terms of protein, generally speaking, the needs for protein in the critically ill population are going to range between about 1.2 grams per kilogram per day up to 2.0 grams per kilogram per day. There's a movement afoot thinking that the metabolism of protein is altered in the critically ill patients, and we may need to increase that further to about 1.5 grams per kilogram per day, if not up to 2 or more grams per kilogram per day. One needs to be careful, however, because you can increase renal stress. But as a general rule of thumb, for most critically ill populations, somewhere in the neighborhood of 1.2 to 1.5 grams per kilogram per day for adequate protein delivery. Let's move on to determining when and how to feed. You should know that specialized nutrition support should be initiated in patients with an inadequate oral intake for 7 to 14 days, or in those patients in whom inadequate oral intake is expected over a 7 to 14-day period. And generally, when determining a route of feeding, you want to consider the nutritional support if any of the following are present. As I said, the patient's been without nutrition for an extended period, roughly 5 to 7 days. The expected duration of illness is greater than 10 days. The patient is malnourished, as for example, having a weight loss greater than 10% of usual body weight. One should initiate nutritional support, and I'm defining nutritional support as needing 2 feeds or TPN, only if tissue perfusion is adequate and the PO2, PCO2, electrolytes, and acid-base balance are near normal. If the GI output is greater than 600 mils per 24 hours, there's a massive GI hemorrhage, prolonged ileus, or other contraindications to enteral feeding, you want to assess whether that is true or not. If the answer to that is no, enteral feedings are generally much preferred and should be initiated as the first option for nutrition support. Hopefully this will be tolerated. If it's not tolerated, or there is that contraindication to enteral feeding, and then at that point one should look at the possibility of administering parenteral nutrition. Hopefully you should initiate a TPN. You should constantly reassess the need for TPN, and if it's no longer needed, then you should switch back to initiating enteral feedings. Let's talk about 2 feedings now. So in terms of initiating 2 feeds, you want to determine if the patient needs a polymeric versus an elemental diet. Polymeric are basically complex forms of macronutrients, such as carbohydrates and protein that are not broken down, such as would occur in the elemental diet preparation. You also want to determine if a patient requires specialized nutrient formula. And so I want to spend a little time talking about specialized nutrient formulas because there are a lot out there, and one of the questions is, are they of benefit? And so I'm going to use our patients with acute respiratory distress syndrome or acute lung injury, asking the question, are specialty formulas indicated in critically ill patients with organ dysfunction? A lot of patients obviously in ICU are intubated, and so this is a group of patients that's worthy of assessing. And looking at the new guidelines, this came out in February of 2016 from the Society of Critical Care Medicine and American Society for Parenteral Nutrition. The suggestion is that specialty high-fat, low-carbohydrate formulas designed to manipulate the respiratory quotient and reduce CO2 production not be used in the ICU in patients with acute respiratory failure. The theoretical thought was that if you decrease CO2 production, that it would improve outcome, decrease length of time on the vent, decrease length of time in the ICU. That has not been borne out by the data, and because of that, it's not recommended that you do need any of these specialty formulas. So the question also comes up is, should ALL, ARDS patients receive an anti-inflammatory lipid enteral nutrition or with antioxidants? And the theoretical basis for this is that if you have enteral formulas, that are soybean based, it is thought that you get an increase in accessible arachidonic acid metabolites, and that can go on to the production of undesired pro and anti-inflammatory effects in the body that can adversely affect the critically ill patient. In contrast, if you add fish oil and you decrease the omega-6 polyunsaturated fatty acids, you get a reduction in the available free arachidonic acid and an increase in your omega-3s, and then you have a more balanced pro and anti-inflammatory effects. And if you increase to having almost all fish oil, you have more omega-3 fatty acids, and then the pharmacological effect in theory is that you have anti-inflammatory effects that may be overall beneficial for the patient. So there was initial data in the early 2000s showing that these formulas did make a difference. But as time went on, people started to restudy this. And this is one study that was published in Critical Care Medicine, phase 2 randomized placebo-controlled trial of omega-3 fatty acids for the treatment of acute lung injury. And they looked at inflammatory mediators both in the lavage fluid from the lungs and in the plasma. And the bottom line is that if you looked at the delta or the change from 0 to day 4 or 0 to day 8, that they didn't really see anything of concern, and they did not see that there was a marked improvement with the institution of this strategy. They then went on to look at certain outcome parameters, and looking at ventilator-free or ICU days, or hospital length of stay, or multi-organ dysfunction score, mortality or 60-day mortality. The bottom line is that fish oil did not seem to have any additional benefit over placebo. And because of this, it threw a little bit of cold water on the use of omega-3 fatty acids in this population. Subsequently, in JAMA, came out a study looking at enteral omega-3 fatty acids, linoleic acid, and antioxidant supplementation. And to the author's surprise, that if you look at ventilator-free days, it was actually lower, meaning it wasn't as good in those patients who had the omega-3s. If you looked at death before discharge, it didn't quite reach statistical significance, but it looked like those who were getting the omega-3s actually had an increased risk of death. And if you looked at a number of days not spent in the intensive care unit, so this group was worse who had the omega-3s. And if you looked at the number of days without organ failure, this was worse in those people who had omega-3s. And then when they looked at things over a 60-day period, those who had the omega-3 supplementation with respect to being alive and breathing without assistance did more poorly than those who had the controlled diet. So because of the mixed results using these specialty formulas, the current feeling by Aspen is that they cannot make a recommendation at this time regarding the routine use of enteral formulas characterized by anti-inflammatory lipid profiles and antioxidants in patients with ARDS and acute lung injury because of this conflicting data. So just to summarize, pulmonary specific enteral formulas are not necessary. CO2 production is generally not a worry if you're not overfeeding the patient. Anti-inflammatory formulas may be harmful and are not recommended at this time. And fluid-restricted energy-dense formulas may assist with overall fluid management. So if you have a person with wet lungs and you're worried about fluid status, then an energy-dense formula may be used, but not a pulmonary-specific one and not an anti-inflammatory formula. So going back to the question that I asked previously, are specialty formulas indicated in critically ill patients with organ dysfunction? I just went through the data regarding people with lung dysfunction, but how about with people with other organ dysfunction, such as renal disease or hepatic disease? And I won't, due to time limitations, go through all of the data, but the bottom line is and based on the current recommendations, based on expert consensus, we suggest using a standard polymeric formula when initiating enteral nutrition in ICU staging. They suggest avoiding the routine use of all specialty formulas in critically ill patients in the MICU and disease-specific formulas in the SICU. And so the bottom line is that these these disease-specific or specialty formulas do not appear to make a difference in outcome unless you're talking about very, very specific situations. When starting tube feeds, you generally want to start about 10 to 30 cc's per hour with full strength tube feeds, and then you want to advance as tolerated toward the goal tube feeding rate. So what are some of the tube feeding complications? Well, there's certainly tube-related ones where you can have perforation or bleeding or malpositioning of the tube. There can be obstruction at the tube, wound infection, the tube quote-unquote falls out. There can be feeding related, so less of a mechanical issue, but related to the feeding of the tube feeds itself. That can be associated with nausea, vomiting, diarrhea, abdominal distension, and bowel necrosis. The biggest one that people worry about and is often talked about is aspiration, because that obviously can be quite morbid for patients. So in order to deal with this, you should look at those patients who are at increased risk. So clearly sedation, an ultrasensorium. The patient location makes a difference. So patients in the ICU tend to be less at risk than patients on the floor, and then obviously is the use of certain drugs that may increase. To help decrease the risk, you want to elevate the head of the bed by 30 to 45 degrees. You may want to consider placement of a post-pyloric tube or into the jejunum, and sometimes people think that prokinetic agents may be used. There may be some thought that by having an endotracheal tube in place with a cuff up, that this somehow protects patients from aspiration risk. But the bottom line is that this does not prevent aspiration risk. And based on expert consensus, they suggest that nursing directives be done to reduce the risk of aspiration and ventilator-associated pneumonia, that should be employed. And in all intubated ICU patients receiving EN, the head of the bed should be elevated 30 to 45 degrees, and there should be a mouthwash used twice a day. The other questions that comes up along the lines of aspiration is what should we do with gastric residuals? And this has led to a lot of controversy over the years and a lot of evolution in the thought about this. What has evolved at this point, and this is in the most recent guidelines in February 2016, it's generally thought that gastric residuals should not be used as part of the routine care to monitor ICU in patients with enteral nutrition. It seems to be wildly inaccurate in terms of how gastric residuals are measured and done. It does not seem to necessarily correlate with a patient's outcome. And because of that, we're moving towards some thinking that gastric residuals not be used as part. However, it's recognized that this is going to be hard for some people to go with. And so they suggest that for those ICUs where gastric residuals are still utilized, that holding EN for gastric residuals at up to 500 cc's in the absence of other signs of intolerance be the new line. Now, it used to be 20 years ago that people would talk about holding tube feeds for residuals 2 times the administered volume, and then it went up to 100 cc's, then 150 cc's, and then 250 cc's. But now we're being much more liberal in the delivery of tube feeds, recognizing the capacity of the stomach, and now go up to about 500 cc's. So if one is using gastric residuals, you want to start the tube feeds generally about 10 to 30 cc's per hour, and you check the gastric residuals in 4 hours. If it's less than 500 cc's, you refeed the residual, resume feeding, advance the tube feed rate according to the MD of PA, and you check residuals every 4 to 6 hours. If the residual is not less than that, you refeed the residual and hold the tube feeds for 1 hour and then recheck the residual. You want to refeed the residual so that you're not throwing away a nutrient. If the residual is still is now less than 500 cc's, you want to refeed the residual, resume feeding at the same rate, and continue checking the residual in 4 hours. If it continues to be high, then you want to discard the residual and check with the MD before resuming tube feeds, and start considering alternative means of delivering enteral nutrition, such as a post-pyloric tube. So, in summary, despite the possibility of life-threatening complications with tube feeds, the risk of such serious complications is relatively low. Tube feeds, especially when administered early, are associated with improved outcomes. Especially enteral feedings have limited role in the ICU. And malnourished patients who cannot tolerate tube feeds, however, TPN is better than prolonged starvation. And so when is TPN indicated? And the general recommendation now is that in patients who are at low nutrition risk, that exclusive PN be withheld for the first 7 days following ICU admission if the patient cannot maintain volitional intake or if EN is not feasible. So if they are admitted at low risk, you do not immediately need to jump to tube feeds or PN. If, however, they're at high risk or severely malnourished and EN is not feasible, then you want to go ahead and start the PN as soon as possible after ICU admission. And in patients with either low or high nutritional risk, use of supplemental PN should be considered after 7 to 10 days if the patient is unable to meet 60% of energy and protein requirements. So when initiating TPN, you want to establish central venous access. There are guidelines about the amount of dextrose or the concentration of dextrose that you can administer depending on the type of catheter that is used. You want to determine the macronutrient concentration and administer approximately 20% of calories as protein, 20% as fat, and 60% as carbohydrate. You want to determine the fluid content, which is roughly 30 cc's per kilogram. Obviously, in the very obese patients, this may give too much fluid. You want to obviously correct abnormalities to avoid refeeding syndromes, such as magnesium, potassium, and phosphate. And you want to start approximately with half the goal solution and advance toward goal is tolerated. A brief word about peripheral parenteral nutrition. It's useful on a limited basis. Patient must be able to tolerate at least 2 liters of fluid per day. You should note that 2 liters only provides about 1,040 calories due to the limitation of the concentration of nutrients that are in PPN. It may be used to supplement inadequate enteral feeding, but it's generally used on a short-term basis. One of the reasons that we don't like PPN is that when it extravasates, it can lead to significant problems as demonstrated in this slide. Some of the common problems with TPN, of course, are hypoglycemia, electrolyte abnormalities. This may be a particular concern in patients with renal failure, refeeding syndromes of patients who are severely malnourished, who get a carbohydrate-dense solution, can have problems with decrease in magnesium, potassium, and phosphate, which can lead to respiratory dysfunction, as well as arrhythmias. There's obviously a catheter-associated infection risk. And one of the things that people focus a lot on is hyperglycemia, because hyperglycemia has been shown to adversely affect outcome. And so what is the general recommendation? You want to shoot for blood glucoses in the range of about 140 to 180. If they are higher than this, then you want to consider upping one's insulin regimen. And in certain complex patients, you may want to start a patient on an insulin drip to help minimize the risk of hyperglycemia. So to summarize and conclude, malnutrition is associated with increased morbidity, mortality, and health costs. One should consider specialized nutrition support when oral intake is inadequate for extended periods. Enteral feeding is the preferred route of specialized nutrition support. One should initiate TPN, however, when the benefits outweigh the risk. And there should be a caveat with all the things that we talked about, that nutrition cannot overcome uncontrolled pathological processes. So if somebody has dead tissue or undrained abscess or uncontrolled pneumonia, no matter what we do from a nutritional status, we're not going to be able to improve things until the primary pathological process is achieved. All right, so let's go over a few review questions. A 70-year-old woman with ischemic colitis pneumonia is admitted to the ICU. She's ventilator dependent and paralyzed. She requires specialized nutrition support, and the Harris-Benedict equation has been used to calculate her basal metabolic rate. Her daily caloric needs are equivalent to her basal metabolic rate, A. B, BMR times the disease stress factor. No activity factor is required as she is paralyzed and vent dependent. C, BMR times an activity factor. No disease stress factor is required because the Harris-Benedict equation accounts for her disease state. D, BMR times disease stress factor times activity factor. E, cannot calculate because the Harris-Benedict equation should not be used for ICU patients. And so the answer is BMR times disease stress factor and activity factor. As I said previously in the presentation, the predictive formulas, including the Harris-Benedict equation, do not take into account the disease stress factor and do not take into account one's activity factor, and therefore you need to multiply by both of these. The activity factor in patients who are moving around in the ICU may be above 1.0, and so you should always include an activity factor based on your best estimate of the patient's activity. The next question. A previously well-nourished 50-year-old male is admitted to the hospital with moderate acute pancreatitis. The following statement regarding his nutrition management is true. A, it is unlikely that he will be able to tolerate enteral nourishment for at least a week. B, enteral nourishment should be avoided until complete resolution of his pancreatitis. C, if TPN's initiation is deemed appropriate, it should be delayed until the peak inflammatory response subsides, approximately 5 days. This strategy will improve overall outcome. D, if TPN initiation is deemed appropriate, it should be lipid-free to prevent exacerbation of pancreatitis. E, it is likely that some form of specialized nutrition support, 2 feeds of TPN, will be necessary. And the answer is C, that if TPN is deemed appropriate, it should be delayed until the peak inflammatory response subsides, approximately 5 days. It should be noted that people with mild to moderate or and sometimes even severe pancreatitis are able to tolerate enteral feedings. And you don't need to avoid enteral nourishment in pancreatitis because it does not seem to exacerbate it. Lipid in the TPN does not seem to affect the time course or the severity of pancreatitis as long as the triglyceride levels are not elevated. And so lipids and TPN should manage in pancreatitis patients in a fashion similar to what is managed for all patients. And it is not necessarily true that all patients will need some specialized form of nutrition support who have pancreatitis. A 60-year-old male whose status post a cerebral vascular accident started on 2 feeds at 30 mLs per hour via NG tube. The nurse finds that there's a gastric residual of 450 mLs 4 hours after initiating the feeds. The nurse should A, refeed gastric residual via the NG tube and continue the 2 feeds. B, discard the gastric residual and continue the 2 feeds. C, discard the gastric residual and hold the 2 feed as the residual is 5 times the rate of 2 feed infusion. D, discard the gastric residual, stop 2 feed infusion, and recheck the gastric residual in 1 hour. Or E, discard the gastric residual, decrease the infusion rate by half, resume feeding, and recheck the gastric residual in 4 hours. And the answer is refeed the gastric residual via the NG tube and continue the 2 feeds. As I said previously, we're being more liberal in terms of the gastric residual volume up to about 500 cc's. And the last question is is regarding the use of enteral formulas in the management of acute lung injury and acute respiratory disease. A, fluid-restricted energy-dense EN formulas may be of use, particularly when the patient is fluid overloaded. B, a high-fat, low-carbohydrate EN formula designed to decrease CO2 production is recommended. C, full enteral feeding is recommended over trophic feeding during the first week of hospitalization when possible. D, EN is not the preferred method for refeeding the acute lung injury. Or E, answers A, B, and C. And the answer is a fluid-restricted energy-dense formula may be of use if the patient's fluid overloaded. High-fat, low-carbohydrate formulas designed to decrease CO2 production have not been shown to be of benefit. Data exists showing that full enteral feeding is no better than trophic feeding in the first week of hospitalization. And EN is the preferred method for feeding these patients, which is also true for all ICU patients.